everyone, my name's Ashley. I'm the ICU educator here at Stonecrest. Today we're going to be talking about some troubleshooting things that you can do for the ventilator in case you are a non-ICU nurse. We're not going to teach you how to run the ventilator or how to set it up. Like I said, just some simple troubleshooting things we want you to be able to do to aid in the patient and the nurse until RT or the ICU nurse can get in there. So we're going to go ahead and talk about the ventilators. This is one type that is seen in the ICU, and then we have a second type. This is just a screenshot, a picture of the other type that you will see in the ICU, okay? And we just want you to know some of the functions, some of the buttons that you can hit, and we'll go over both of them. So we'll start with a scenario that you are sitting out at the nurse's station and the ICU nurse, the doctor, and respiratory therapy are in a patient's room intubating the patient. You hear a ventilator alarm. You want to get up and don your PPE and go into that room and see what's going on. See if you can troubleshoot. So when you go in the room, the first thing you need to do is look at the monitor and look at the patient as you walk to the ventilator and silence it. Most ventilators have a silence button on them. It's usually denoted by a little bell symbol with a line drawn through. This is on this one, and then on the smaller one, it is in the left-hand bottom corner. It's kind of hard to see on this picture, but it's in the left-hand corner, okay? That is the silence button. So once you hit the silence button, look at your patient, okay? Are they wide awake, biting the ET tube, shaking their head, moving around? If they are, then it means they're probably not adequately sedated. So look at your Alaris pumps, see what's going on. Could the sedation need to be increased, or maybe the nurse came in a few minutes prior and didn't hit restart on the pump, and so the patient hasn't gotten any sedation. So that's one way you can troubleshoot if they're wide awake. The second thing to do is look at your IV. Make sure it hasn't infiltrated and you've got your sedation medications going into the subcutaneous tissue. So that's two things you can do right there if they are wide awake, biting the tube, okay? So let's say you come in and they are sound asleep, but the ventilator is alarming. And you look at their tube and you see some secretions. Well, we want you to feel comfortable to suction them. And we will go over suctioning here in just a minute. So let's recap. You walk in the room, they're sound asleep, you see no secretions. Next, we want you to check all your tubing. Eye trace. Make sure the lines are secured. Sometimes our vents can come unplugged, and if they do, the alarm will obviously go off on the ventilator. So check all your connections. Make sure they are on good, and follow them all the way back up to the ventilator. Okay? Once you've checked your lines and you've seen that the patient's asleep and there's no secretions that need to be suctioned out, but the ventilator is still alarming, you need to go ahead and call for help. Knock on the window, wave at somebody outside there, ask for help, because you've done some of the troubleshooting things. Look at your monitor. If their sats are starting to drop, you can hit a button on here called O2 suction. What this does is it delivers 100% FiO2 or 100% oxygen. Here's your button. And it will show on the ventilator that it's delivering 100% FiO2 or oxygen over a certain amount of time, usually 2 minutes. On the newer vents, it's on the left-hand side, and this is it blown up right here, okay? So just hit that button to deliver 100% oxygen. And at that point, you've already called for help and you have somebody coming in there, okay? So say you give the 100% FiO2 over 2 minutes, and the patient, their oxygen saturations go up, but then they start coming back down. The next thing we want you to do is, when in doubt, bag and shout. We want you to take the patient off the ventilator, grab the ambu bag, and start bagging the patient, okay? All ventilated patients will have an ambu bag at bedside. Ensure that it is going up to the flow meter and it's turned all the way up, okay? So you're going to give one breath over 5 to 6 seconds, okay? You give them a breath, you take a breath, because it can be a stressful moment of what's going on. So you may have to bag for 5-10 minutes until they get done with that intubation in the next room and can get over there, okay? So that's just some of the troubleshooting items that you can go through, look at to see what's going on with the patient. Now, let's go back to suctioning. So remember I said the patient could possibly have secretions in their ET tube and they need to be suctioned. So when you come into the room and you see the secretions, you're going to go ahead and give them 100% oxygen. It's called pre-oxygenation. You're going to pre-oxygenate by hitting the O2 button to give 100% FiO2. Remember, these patients are typically really sick and they're dependent on their oxygen. They don't have a lot of reserve, okay? So while that's giving the breath, go ahead and look at your inline suction, okay? You should have suction tubing going up to a suction canister. And here is where you'll press down to do the suction. Sometimes you'll see the suction turn that way, or it will be locked and you cannot press the button down, okay? So go ahead and ensure that it is able to press. Okay, you don't want to start suctioning the patient, get the catheter in, and then you're trying to figure out what's going on. So your O2 breath or 100% FiO2 has been given. Now you're going to grab the ET tube to help guide it in, and you're going to start advancing the inline suction catheter. You're going to go until you meet resistance. When you meet resistance, pull back 1 to 2 centimeters, and then start pressing the suction button intermittently as you pull out, okay? This should take less than 15 seconds. After you do that, the patient will probably cough, gag, their oxygen saturation may drop. If it does, you can go ahead and give another O2 breath. The patient may need to be suctioned again, but if their oxygen sats are low in the 80s, don't suction again. Let them get the O2 breath and recover and see what's going to happen. If they recover and their sats do go back up to 88, 90% and they still have secretions, then start the process again. Pre-oxygenate, make another pass, and then intermittently press the button as you withdraw the suction catheter. And then once again, look at your oxygen level and give another O2 or 100% FiO2 if need be, okay? Like I said, these patients could be really sick and they may already be on a high level of FiO2. And after you suction them, they do not recover and their sat stays 75, 80. Respiratory may be aware and they may ask you to turn up the FiO2 setting. This is one button that you can touch on the ventilator. It is right here. So if the patient is at 50% FiO2, they may say go up to 60% FiO2 or 70% FiO2. And this is only temporary, just to help the patient catch up, to help build back up their reserve. So what you would do is you would press this button and you would toggle to whatever selected FiO2 the respiratory therapist recommends. So we'll go to 70%. So there we go. There we are. And then press the button and now it's set at 70%. Okay? The same thing applies to the other ventilator. So here's the smaller ventilator. Down in the right hand corner is where you will change the FiO2 on this one. Here it is blown up. Same thing, you will select the FiO2, you will toggle to the prescribed FiO2 that has been set forth by the respiratory therapist, select that number, hit the button again, and then you should have a new FiO2. Okay? The last button that you may be asked to change is the PEEP. And once again, it's down here on the bottom beside the FiO2 on the newer ventilators. Same thing, you will press the button and then you will toggle to whatever level you need to, okay, and then set that. On here, the PEEP is located right here. Same thing, you'll mash the button and then you'll go up to whatever preset PEEP that's recommended, and once selected, you will press the button and now the new PEEP will be set. So say you suction the patient, they drop their oxygen sats and respiratory therapy recommended going up on their FiO2. Now it's been an hour and their oxygen level has finally evened back out or went back to its baseline, 88, 89, 90. You may need to go back in there the next time you're doing a task, giving medications, assessing the patient, and tell the respiratory therapist, hey, I'm going back in there. Would you like me to go down on the FiO2? If they say yes, same thing. You're going to select it and then go back to what it was originally set at, 50%. And then select. Same thing for your PEEP. These are just been some things that you can. These are some things you can do just to help troubleshoot while a respiratory therapist or the ICU nurse or even the MD can get in the room to troubleshoot. Okay? Thank you.